My name is Graeme Fraser. I'm a hematologist at the Jervis Cancer Center in Hamilton at McMaster University, and I was chairing the CLL session. We had a fantastic session this year. One talk focused on prognostic markers in untreated CLL patients, and then we had a discussion about ibrutinib failure and allogeneic stem cell transplant. And I would say that key take-homes from each of those presentations, number one, on the prognostic factor side, we reviewed a lot of the exciting recent data around prognostic marker development and integrative prognostic models and how they are going to be important in integrating into clinical trial development and may become important, therefore, in patient care. But that there is a number of markers that aren't available in Ontario and across the country, and really a need, I think, to have a discussion and an open dialogue about what markers represent a standard of care. Right now, I think it's very clear that access to interface FISH testing and p53 mutational testing is important because patients with a 17p deletion or p53 mutation have poor outcomes in terms of both progression-free and overall survival. Currently, p53 mutational testing is not done. There's maybe a little bit more debate about the impact of immunoglobulin heavy chain mutational testing, but certainly a mutated genotype is associated with excellent outcomes after FCR chemotherapy or chemoimmunotherapy, and these markers are important in terms of being able to utilize clinical prognostic indices. Dr. Davids from the Dana-Farber gave an excellent presentation about how to manage patients who are either intolerant to or who are resistant to ibrutinib. And I think key take-homes from that talk included the promise of novel agents. In particular, hopefully we will have access soon to additional agents that target either B-cell receptor pathway inhibiting, such as idelalisib and rituximab, and some very promising data that he shared with venetoclax and the activity of that medication both in the 17p population and in patients who have failed B-cell receptor pathway inhibitors, as well as a number of exciting new molecules that are under development. And Dr. Seftel gave a great presentation about the evolving role of allogeneic stem cell transplantation, highlighted the fact that probably there has been a change in, at least in the frequency with which allotransplant is being offered and provided, in part because of the excellent results with novel targeted therapies. But there is clearly still a group of patients who either are high risk biologically, who fail novel agents that may well be very appropriate to consider for allogeneic stem cell transplant. So there still is a role for allotransplant. I think there's going to be a number of issues in that area that require further study, including the optimal patient selection. And he spoke a lot about some of the challenges of donor selection and some evolving transplant technologies that are likely to be appropriate and useful for a CLL population of patients resistant to novel agents.